I'm Marty Murphy, and I'm happy to welcome you to this educational session developed and hosted by the Society for Translational Oncology. Entitled Breast Cancer, New Treatments and Improved Therapies, this dialogue will describe more effective and less toxic breast cancer therapy with implication for a better understanding of cancer metastasis and cancer stem cell biology. If that's not challenging enough, you will also learn how a 19th century amateur mathematician contributed to a 21st century breakthrough in breast cancer treatment. Treatments that could result in a 26% decrease in relapse and a 31% decrease in mortality. Dr. Larry Norton, Deputy Physician-in-Chief for Breast Cancer Programs at Memorial Sloan Kettering Cancer Center in New York, is responsible for making this remarkable and promising connection, one that bodes well for breast cancer patients. Called dose-dense chemotherapy, Larry and a team of his colleagues at Memorial have been advancing the science that underpins his original clinical observations, and at the same time, they have been seeking to improve patient outcomes. To help us better understand the biology and clinical impacts of dose-dense chemotherapy, and to appreciate the role of a 19th century actuarial, we are going to be treated to a dialogue between Dr. Norton and Dr. Bruce Jabner. Like Larry, Bruce is an internationally recognized leader in the treatment of cancer. He is clinical director of the Massachusetts General Hospital's Cancer Center and associate director of clinical sciences of the Dana-Farber Harvard Cancer Center. Prior to his current Bostonian positions, Bruce was director of the Division of Cancer Treatment at the National Cancer Institute. In that position, he was responsible for all NCI cancer therapy research. It was during those years that a young Larry Norton first arrived at the NCI, and the paths of these two great men crossed for the first time. Bruce, would you please take it away?
Thanks, Marty. It's a great opportunity to hold this small meeting of three people and to think about where we've gotten in breast cancer adjuvant therapy. And I guess the story begins with some people at NCI who supported trials and encouraged trials, and fortunately Larry arrived on the scene just about the time that this was all happening. Larry, I'd be interested in hearing your reminiscences about where this field began.
Yeah, well, Marty was very kind in saying that I'm responsible for where we've gone with this. But in fact, I've just been part of an ongoing process. And you can have a whole long list of individuals that I've had the privilege of working with and being influenced by and mentored by over the years, really, that have led to this. And obviously my collaborator on the mathematics, Richard Simon, has to be really very much at the top of the list. But Bruce and your colleagues at the NCI in those days, Vince DeVita, Paul Carbone, were extremely important in what I've been able to do. So I've been part of a historical continuum, really.
So let's explore some of the ideas that led to adjuvant therapy. First of all, there was the recognition of the problem that breast cancer surgery was often not successful in curing the disease, and what could we do to turn that situation around. And so the early experiments in this regard were done by Bernie Fisher and some other surgeons who showed that a single agent could change the outcome for women with breast cancer. Now that must have influenced you greatly, because you jumped on that like a puppy on a bone.
Well, it was exciting to me for a variety of reasons. Even before I started doing my own thinking in this regard. One of them was the notion that really did originate with Bernie Fisher, that cancer cells spread beyond the area of the primary tumor very early, sometimes so early that even with the earliest diagnosis of a breast tumor, for example, you already have dissemination of disease. That was clearly one important observation. The second was really theoretical modeling. It came from the work of Howard Skipper, Frank Schabel, Dan Griswold, and others, where they actually did mathematical modeling using very simple models to illustrate the idea that if you can start therapy of micrometastases very early and treat aggressively, we could talk about the definition of the word aggressive in a moment, that one could make a very concrete difference. And that really is where it really started. That caught the imagination of many of us there. And I was fortunate to be at the NCI with you at that time, you being one of my mentors in that period.
I was very fortunate to be there.
When some of the earliest applications of those ideas, in particular the use of single-agent L-phenylalanine mustard as an adjuvant therapy, post-operative adjuvant therapy for breast cancer, some of that data started coming out. Because it was an NCI-sponsored trial through the NSABP and Bernie Fisher's leadership, we got to see, as clinical associates, the data very, very early. And I remember very specifically the meeting where the early data was shown to us, and we all looked around at each other and said, obviously cancer is going to go away very, very quickly because of these discoveries, and we're going to have to think how we're going to use our training to do something else.
So the issue was we had some success with single-agent chemotherapy.
Right.
This was mainly in women who had node-positive disease, and there was an improvement of survival ultimately, maybe 15 to 20% in those patients.
Right.
But clearly that had to be refined, and one of the things that was going on was more aggressive therapy of advanced disease. There was a regimen, the Cooper regimen, which incorporated 5 drugs that was first talked about at an ASCO meeting in the late 1960s that had impressive response rates, better than single agents. So why not use combinations in adjuvant therapy? And the CMF regimen was then tried. It was actually done on a contract at NCI with Johnny Bonadonna, and again, a more positive result and more encouragement. But at this point, Larry enters the picture, and he's working with Richard Simon at NCI, and they had the idea that maybe we could use these drugs in a more intensive way. And what was that idea?
Well, the big issue was why wasn't it working better? Everything suggested that we were coming in very early with the drugs. We were using combination chemotherapy according to MOP principles, which were developed at the NCI. That was using active agents, using them in the best dose you can in an active combination, non-cross resistance if at all possible, different toxicities so that you can use them in a combination. What we all called, and people still call it, the MOP principles of chemotherapy. All the kinetic models coming from Skipper and Schabel and colleagues were indicating that this should be extremely effective. And we were clearly having an impact, but we were not having a huge impact. And so the real question was not why it worked, but why wasn't it working better? And in wrestling with that issue, and in very specific cases, there was a patient with lymphoma, malignant lymphoma, for example, that we had very careful measurements on the tumor volume. We saw it shrink, we saw it disappear, we saw the patient relapse from complete remission. And when we tried to fit mathematical models to that data, we were not getting something that was sensible by our understanding at the time. That's where we started thinking, and that's where we discovered the work of Benjamin Gompertz, this 19th century actuary. Actually, Anna Laird had written a series of papers in the middle part of the 20th century, early to middle part, where she actually demonstrated that experimental animal tumors were growing according to this Gompertzian kinetics, and was well established. So it was out there in the literature. Not so many people were paying attention to it. And what Richard Simon and I tried to do, basically, was say, okay, let's imagine that these tumors are growing by Gompertzian kinetics. And if they are growing by Gompertzian kinetics, and the Skipper-Schabel observation is a true observation, that is log kill, what does this all mean? Where does this lead us? So the Norton-Simon model was basically taking the observations of Skipper-Schabel and making them make sense in a Gompertzian environment. And what we found is that it basically led to conclusions about the optimal way to use drugs that was not intuitive.
So some of those conclusions, which seem obvious now but weren't obvious then, was you had to maintain dose intensity throughout therapy. The tendency, as I well remember with the lymphomas, was to treat like crazy up front as much as a patient could tolerate, and then as the tolerance decreased, to back off. And Larry's idea, which was much argued at the time among the clinical fellows, particularly down in the cafeteria at NCI, was don't let up. Actually, it counted even more as the tumor got smaller. You got greater cell kill for a given dose of drugs. So that was
that's exactly
a key finding.
That's exactly right. And indeed, what we were doing commonly, you've hit the nail on the head, was was the worst thing you could do in terms of eradicating cancers if the model was holding. The other thing that wasn't all that clear to us, but became clear over time, is this whole issue of what does dose intensity mean? Many of us, myself included at a certain point, were enamored of the idea of pushing the amount of drug per administration as high as we possibly could. And yet the data already existed in animal systems suggesting that fundamentally you can't kill a dead cell.
Yes.
Once you've actually killed all the cells that can be killed by a drug, pushing the dose higher.
At that point in time.
At that moment in time, in that administration, once you've done that, pushing the dose higher was not going to achieve any more cell kill.
And we've actually seen that in some of the lymphoma studies where we tried to double the dose of non-Hodgkin's lymphoma therapy and got no added benefit from it. But the opposite the approach would be to shorten the cycles. So don't leave 2 weeks of free time for the tumor to grow. And the original cyclic chemotherapy was based on lymphoma experience, where 28 days was the cycle, 14 days of treatment, 14 days of rest, and we were giving the tumor an opportunity to come back.
Right.
And so you've changed that in your thinking in breast cancer to a 14-day cycle.
Well, the model clearly demonstrated that the schedule of administration was as important as the dose administered. And the model clearly indicated that you find the dose that's your best dose for getting cell kill, as you can do with agents. In breast cancer, for example, all the agents that we're now using in breast cancer have been studied. NSABP looked at cyclophosphamide up to 2.4 grams per meter squared and found it was no better than 600 milligrams per meter squared, for example. With doxorubicin, once you get over 60 milligrams per meter squared, there's really no benefit. Paclitaxel, once you get over 175, there's no benefit. So the fact is that you find your optimal dose and then you basically give it as often as possible. And that is a more sensible way of treating. Of course, the discovery of the activity of the granulocyte colony stimulating factors, particularly GCSF, was critically important. And indeed, the thing that prompted my move to Memorial Sloan Kettering Cancer Center was over breakfast one morning reading a report about the treatment of bladder cancer, where there was a one-line statement. It was the use of GCSF in that setting, and there was a one-line statement there in that paper that said, "Oh, by the way, we noticed that the counts recovered so fast that we could treat again on day 14." And
I guess
when I saw that, then all of a sudden all the lights went off in my head, and I said, "That's exactly what we should be doing in the treatment of breast cancer."
Yeah, well, I think we need to give other people credit here. There was an attempt repeatedly to shorten cycles and intensify doses, but until the growth factors were available, you couldn't do that on a routine basis. You couldn't write a regimen that 75% of the patients would tolerate, but now with growth factors, it's feasible.
Yeah, but totally true. But part of those attempts was going as high as you can, as often as you can.
Yes.
And I think that there's a tremendous confusion out there about that point. Going as high as you can turns out not to be so important. And now we have a lot of clinical trial evidence in malignant lymphoma as well as in breast cancer that going as high as you can is not necessarily what you have to do. We're seeing some confusion out there even in existing modern attempts, modern regimens that are trying to do this, of going as high as you can, as often as you can. It is not necessary to go as high as you can. You have to find the right dose, and then you have to give it as often as you can, and the right drug.
So that's the next phase of this story. Adjuvant therapy, I think, is headed in the direction of selecting subsets of patients and treating them appropriately with different regimens. So maybe you can talk a bit about that, Larry. How do you see that moving?
Well, that's the current topic of greatest interest, is that breast cancer is not one disease. Breast cancer is a collection of diseases, and it's anywhere between 3 and 7 diseases.
So what are some of the important subsets that you see now?
Well, clearly the very estrogen-dependent cancers, which we're calling luminal A's, of infiltrating ductal cancer, that's clearly one easily identifiable subtype. The basal breast cancer, basaloid or basal type breast cancers, we also call them triple negative, estrogen progesterone receptor negative, HER2 negative, probably has a myoepithelial stem cell origin.
And a different response to treatment.
It's an entirely different disease, all right?
And this is the one that there's experimental evidence that's platinum sensitive and has problems with DNA repair.
Absolutely, and that's a different disease. HER2 dominant, and not every HER2 amplified overexpressing cancer is HER2 dominant, clearly, but nevertheless HER2 dominant where the cell cycle is being driven by HER2 and other and EGFR ligands going through those dimerization pathways. That is clearly a subtype, and that's of course where trastuzumab is clearly playing a major role.
Yes, and we have this new drug now, lapatinib, which is making a big entry into adjuvant therapy. Some very large trials now starting, which will broaden the number of patients that have access to this therapy.
But Bruce, I want to emphasize it doesn't change the fundamental principles. This, I think, is an important point that we have to recognize. Just having a drug and even knowing the target doesn't not make an optimal therapy. You have to know how that drug should be used, all right?
Yes.
We had cyclophosphamide, we had methotrexate, we had 5-fluorouracil in the CMF combination.
Yeah.
We saw activity there in Bonadonna's original experiments, and that data is still holding up. But was that the optimal way to use those drugs? Is using them in simultaneous combination optimal? If you have to reduce the dose levels of your drugs to force a simultaneous combination, is that sensible? Is your schedule right? Now, as we develop targeted therapies for all of the molecules that we're talking about, it's not going to be enough just to say, we've got a drug, we've got the target. You've got to know how to use it. And I fundamentally feel that, and I think we've got the evidence that we're talking about today to demonstrate that mathematical principles
will still apply.
are going to be useful.
Yeah, sure.
Understanding the kinetics of tumor growth is still going to be a very important component in this process.
I think, and I think the other concept that's very important to emphasize is that although we're developing these targeted molecules, we're still depending on the cytotoxics in most situations, maybe with the exception of hormonal therapy. But even there, we're using that in sequence with combination therapy. But certainly with Herceptin, with lapatinib, we're going to head in that direction, I'm sure. And with Avastin, another important drug in breast cancer in the future, we're going to depend on the cytotoxic chemotherapy. And the principles that you've outlined are still going to apply. You're going to need dose density and intensity of appropriate degrees to get maximum benefit.
Yeah. Well, that was something that was derived specifically for cytotoxic therapies. We had it in those days. I think as a more general rule, a mathematical understanding of tumor growth is going to guide us as we move forward into designing better therapies using all of these agents. So, I don't think that it's so clear cut about how we should proceed. The one thing that is clearly so, however, is that when you have agents where the dose-limiting toxicity is marrow suppression, and that's what's preventing you from coming in as often as you can, that can be ameliorated now. And that is a very important tool that we can have for getting the maximum impact out of those agents. And I agree with you that still killing dividing cells is going to be an important part of whatever we do as we evolve into the future.
So let me ask you a question, which I've thought about a lot and I have no answer to. Maybe I have some suggestions about it, and that is, how do we quantitate the kinetics of cell kill? Is there any, do you see in the foreseeable future a way of doing that clinically without rebiopsying tumors?
Yes.
And are we really making progress in terms of developing the tools to know how fast we're killing tumors?
I think we're actually getting those tools. We haven't really applied them optimally in the clinic yet, and we may be a little bit away from applying it, and that is PET scanning,
right?
MRI, MR SPECT, where we can actually look at, and not just look at glucose utilization, for example, but actually start to look at
kinetics,
at kinetics, and to look at more other molecules that may be very important.
So
in
I
this
think
process.
my feeling is that an important part of the characterization of a tumor before treatment in the future will be some measure of the proliferative rate and some measure of the impact of your therapy on that proliferative rate.
I agree completely.
And I think we'll be looking at not only biological but mathematical subsets of
and
tumor.
everybody's talking about the importance of designing optimal treatments for the individual patient. In other words, tailoring therapy. It's not going to be enough to know the molecules that are making the cancer a cancer. It's going to be important to know how those change over time.
How they integrate also.
Kinetics, how things move over time, the evolution of these things over time is going to be a very important part of the process.
One of the things, Bruce, if I could interject, is that is driving a lot of this is that dose dense does not necessarily mean more toxic.
Oh, it's actually less toxic.
And-
I mean,
and-
that's
and
that's-
there-
Yeah,
you know-
and when you think about the fact that you're shortening the duration of therapy for that patient from 6 months to maybe
4 months. It's
3
1/3.
months or
Yeah,
4 months.
right, sure.
It's a lot less toxicity and a lot less misery for the patient.
Yeah, but even during the period of treatment, it's less. And that's actually, I kick myself for choosing the word dose density. I was thinking like a mathematician. To get the doses closer in time is denser. There's an implication for people who aren't following this carefully that by giving the drug more often, you're getting more toxicity. In fact, in breast cancer, in the trials that we've done, you're actually getting less toxicity across the board. In some patients, they develop a mild anemia that could be easily treated with erythropoietins, in fact, and even prevented in that case. But in every other toxicity, certainly hematopoietic toxicity in terms of granulocytes, it is better. But even in areas such as cardiomyopathy, neuropathy, for example, is actually less toxic.
Less toxic.
So that a major reason why one would want to give dose-dense therapy for breast cancer, for example, and same is true of lymphoma, as we're finding out as well, is it's a less toxic approach. It's shorter and less toxic. It just also happens to be more effective, right? That's actually why I can't see why there would be a reason not to do it. Every indication would be that it would be a superior way of treating the patient, just on the issue of toxicity and length of time the patient's being treated. In addition to that, you're getting more efficacy.
So Larry, I think we've accomplished a lot. What is, let's sort of set the stage now in the present time for what we can accomplish with adjuvant therapy. For node-negative disease, most patients are now curable, will not have a recurrence. With appropriate adjuvant therapy, probably 85–90% of patients are free of disease for prolonged periods of time, if not cured. For node-positive disease, are we making progress?
Yeah, well, the node positive is where you see it, and actually, it's in the highest risk node positive where you see the biggest benefit, and that's the estrogen receptor negative subset. Estrogen receptor positive is going to take time before we know. It takes a very long period of follow-up to know the impact of your therapy in that regard. But I do believe that finding the molecules responsible for the growth and then targeting those and using those in the optimal fashion, which may well be dose dense, is the way to go.
So we have two good examples of that now. Herceptin is one, and then the other one is Avastin. What do you see the future role of Avastin being in breast cancer?
I think it's critically important to understand more about the biology of those agents. Just as when we started using chemotherapy, we said it's enough to have a drug that kills dividing cells, let's just sort of give it, and that's all we have to do. And we learned that scheduling and integration with agents is important. I think we still have a lot more to learn about trastuzumab and bevacizumab in terms of how it should be optimally utilized. And in that regard, I think we have some very recent observations that I think may be very relevant as we look forward to the future. For example, I believe that we're on the verge of really understanding why things grow in a Gompertzian fashion. And understanding what the biology is that leads to that. And it has to do with the process of metastasis, the process of tumor-initiating cells, or sometimes called stem cells, being very important, not only for the metastatic process, but also important for the growth of the primary
local
tumor.
Yes.
Yeah, and the geometry of where those tumor-initiating cells are could be really vitally important. And those things can be disrupted with targeted agents, and that could potentially make a huge difference as we move.
So you and I were talking before this session began about two observations, one that your group has made, another that was published recently in Cell. The Cell observation was that stem cells from the bone marrow are critical in setting up the environment for sites of metastasis for cancer cells. So understanding normal stem cell biology, and particularly endothelial precursor cell biology, is going to be extremely important in designing adjuvant therapy, and perhaps creating a very major role for drugs like Avastin and other drugs which affect angiogenesis. Your group has been working on the local metastasis
and on blood vessels too. Robert Ben Ezra in our group is also finding that the blood vessels in the tumors are coming from endothelial stem cells coming from the marrow. And again, that in a migratory pattern. What Jean Massaguet in our group really has identified are signatures, gene expression signatures that are associated with site-specific metastases. These things also affect the growth of the tumor. Indeed, it's starting to look to us that the tumor itself is a metastatic site, that tumors reseed or self-seed, the same way weeds in a garden self-seed, and that process involves blood vessels and involves migration, and all of those are potentially new targets.
Larry, in pursuing this idea of mathematical modeling for adjuvant therapy, I think it would be helpful for you to explain in simple terms, non-mathematical terms,
Absolutely.
what a Gompertzian curve looks like and what it means.
Well, let me just show it to you on this figure.
Well, this figure here shows what Gompertzian growth looks like. You can see the cell number is on a logarithmic scale, so 10 to the 3, 10 to the 4, 10 to the 5, etc., going up, rather than the arithmetic scales we normally see scales. But the weeks, or any kind of unit of time, is on an arithmetic scale along the x-axis. And you can see that the growth bends over continuously over time. You can think of Gompertzian growth as a series of exponential curves, which would look like straight lines on a semi-logarithmic plot, but that each line has a decreasing slope compared to the line before it. And that's because in Gompertzian growth is always slowing down. Indeed, everything that we know in nature grows by Gompertzian kinetics. If it didn't, we would see that everything growing would keep growing until it filled up the whole universe. Obviously, that's impossible. And everything that grows naturally reaches sort of a plateau phase of no further growth. Now, of course, if a tumor grows this way, and we have ample evidence that tumors do grow this way, we have to perturb them, we have to shrink them. If we look at the next figure, we can see the influence of therapy is symbolized by those arrows. And with each dose of therapy, you get shrinkage of the tumor, but of course you get regrowth of tumor between cycles of therapy. The overall effect you can see is to reduce the tumor volume, and then when therapy stops, of course, unless you've eradicated the tumor regrows. Now, something that's very interesting about Gompertzian growth, and this is what Richard Simon and I observed, it became the Norton-Simon hypothesis, is that the rate of regression is always proportional to the rate of growth. And what this means is shown in the next figure. In this figure, what we see is that by treating earlier on, and the arrows again symbolize earlier treatment, compared to the same treatment that was given in the previous figure a little later on, we are actually getting more regression with each dose of therapy, more cell kill, more proportional kill. We also call it more log kill. The reason is very simple. The tumor is growing more rapidly, and therefore it's going to regress more rapidly when we treat with the given therapy. And the overall cell kill, you can see, is greater by treating earlier than if we were to treat with the exact same therapy later on. Now, this actually has a very interesting implication. And that is that although the log kill is greater by treating earlier, the eventual outcome is the same if you don't eradicate the cells. And the reason the eventual outcome is the same is because the regrowth is faster. You've killed more cells, you're down to a smaller tumor volume, but it's a Gompertzian tumor that grows relatively more quickly when it's small than when it's big, so it catches up. And this might indeed explain why a lot of our therapies, giving them earlier, giving them more aggressively, giving them in various manipulations that cause increased response rates, do not necessarily translate to increased survival. The reason is that yes, we can get better response to therapy, but the regrowth may be very quick, and as a consequence of which it may wipe out that benefit, and the eventual outcome is the same.
In order for our listeners to understand what you mean by dose density, I'd like to have you show us a regimen and how it's changed when you create a dose density.
All right, let me show it to you in this figure.
Well, if we refer to the model that you saw in the previous figures, and I show here what happens to the Gompertzian tumor if it's treated late and then when it's treated earlier as an example, if you were able to squeeze the treatments together closer in time, you'll notice, well, with the first treatment, you get the same log kill or the same cell kill that you got with the first treatment before. But we come in with the second treatment much sooner. And as a consequence of that, the time of regrowth of the tumor is much less. So the tumor is smaller when we come in with the second dose of therapy. Because the tumor is smaller, because of the Gompertzian phenomenon, We get a greater cell kill with the second cycle of therapy, and then we come in with a third cycle again with a reduced time to allow the tumor to regrow, and because it's smaller yet, we get even greater cell kill. Remember that the rate of regression is proportional to the rate of growth. And the fourth cycle comes in at a very tiny tumor size when the growth rate would be very rapid. And because the growth rate is so rapid, at that point we get a very brisk cell kill, and actually in this example, we eradicate the tumor. So the simple manipulation of treating sooner by limiting the time of regrowth of the tumor gets translated, because of the Gompertzian phenomenon, into increased cell kill and a very significant benefit to the patient in terms of tumor eradication or significantly shrinking the tumor, and therefore adding considerable time to the tumor regrowth. And that's how dose density works. It really is a way of treating smaller tumors by giving less time of regrowth between cycles of therapy. Now, in these examples that I showed you, I keep the dose level of chemotherapy the same. I do not escalate the dose level. There is a right dose level that causes the maximum amount of cell kill compared to the toxicity of the therapy, and that right dose level is the one we should be using. We should just use it as often as possible, because if we use it as often as possible, that's how we're going to accomplish optimal cell kill and greatest benefit for the patient.
Okay, so I think we'd like to wrap things up here, and there are a couple points to emphasize. All of this that we've talked about has to be proven to be useful in patients, and that means doing clinical trials.
Right.
You've been very fortunate to have a number of colleagues that have been instrumental in organizing those trials and playing a significant role.
Well, yeah, I think it's very important to emphasize is that all parts of the system have to work. You need volunteer patients, and we need more of them coming into these trials. But the design of clinical trials is an area of great creativity, and often that creativity is not represented in the same way that it is in laboratory investigation. There's nothing that I've done that I could have done by myself by a long shot. People like Cliff Hudis, Andy Seidman, my colleagues at Memorial, all of whom made major contributions to the design of the regimens, the pilot studies that led to the trials that you see here, people in the Cancer and Leukemia Group B, Eric Weiner, Don Berry, our statistician, all of these people are critically important and should be respected as scientists, the same way laboratory scientists are respected in terms of the design of studies. The conduct of these studies is how we make progress. It's not enough to have an idea. You have to test it, you have to refine it, and all parts of the whole system have to work together.
Yeah. You and I were fortunate to be part of a group of very willing participants in clinical trials, people that were willing to design trials, to put their patients on trials, and of course the patients deserve all the credit as well.
Absolutely.
In 1825, a London East End insurance actuary, Benjamin Gompertz, theorized that growth followed a common curve. Rapid growth occurs first, followed by slower growth. From this insight, Larry Norton, whose breast cancer research career spans 30 years, developed with his NCI colleague, Dr. Richard Simon, their cancer biology hypothesis. The Norton-Simon collaboration has led, on the one hand, to an improved understanding of the nature of tumor cell biology, whilst on the other, it has brought about a profound shift in our appreciation of how these precepts may apply to the clinical treatment of human malignancy. The fruits of their research serve to illuminate new therapies and improvement in existing therapeutic regimens. As with many fundamental shifts in our understanding, the translation into community-based practice has taken, however, considerable time, and it is far from complete. That is one of the prime reasons for holding today's dialogue. The Society for Translational Oncology has been proud to host these presentations, and we are deeply grateful to Dr. Norton and Dr. Chabner for their stimulating and entertaining discussion. We are also thankful to our benefactors for their unrestricted grant support, and to our excellent producers, Michael Lawrence and Trevor Lawrence. Thank you.